see temporomandibular joint. So first we are going to see about the normal range of motion, capsular pattern, open pec and close pec position for TMJ joint. Normal opening is 35 to 50 mm and approximately 40. If we want to do some functional work like eating, chewing something, so for that the functional opening is 25 to 35 mm. At least 2 to 3 knuckles go inside the teeth. Protrusion 3 to 9 mm, retrusion 3 to 4 mm, lateral deviation 8 to 10 mm. The open pec position means jaw open slightly and it is the free way between the space. The closed pec position, the maximum retrusion or closed teeth plus clenching of the teeth maximally open the mouth. This is the closed pec position. When the patient is having limited mouth opening, remember it is a capsular pattern of that patient. So if the patient is opening their mouth and C-shaped deviation is there, that means hypomobility towards the side of deviation and the lateral pterygoid muscle is involved or disc is involved. If the S-shaped deviation is there, then muscle imbalance or displaced condyle around the disc. Let's see the type of joint. TMJ is a synovial compound and modified ovoid bicondylar joint. It is formed between articular eminence of temporal bone and intra-articular disc plus head of mandible. We can see here, this is the condylar process, this is the mandibular fossa and this is the temporal area. So it is formed here. This is called temporomandibular joint. Let's see the nerve supply action of temporalis muscle. The temporalis muscle is originating from the temporal fossa and it inserted to the coronoid process and the ramus of mandible. The nerve supply is by trigeminal nerve. The action of temporalis muscle is unilateral and bilateral. If it is contracting bilaterally, means both the side, so ipsilateral deviation will occur. If it is contracting unilaterally, so it will close the mouth. The closing mouth is also known as elevation of the mouth and it is help to retrusion of mandible. Insertion, nerve supply and action of masseter muscle. It is a powerful mastication muscle. Origin is from zygomatic arch of maxilla and temporal bone of the mandible. Insertion near the coronoid process and the ramus of mandible. The nerve supply is trigeminal nerve. Main action of masseter muscle, if it is working unilaterally, means ipsilateral deviation of your mouth. If it is working bilaterally, both the side, that means it will help to close your mouth. Let's see medial pterygoid muscle action, nerve supply and origin. The medial pterygoid muscle is origin at the tuberosity of maxilla. This is medial pterygoid muscle. This is lateral pterygoid muscle. It is originated at the tuberosity of maxilla. It inserted at the medial surface of ramus and the angle of mandible. Mainly the nerve supply by the trigeminal nerve, but the mandibular branch of trigeminal nerve. If the medial pterygoid muscle is working unilaterally, means it will helping our muscles or our jaw to contralateral deviation and protrusion. If it is working bilaterally, that means elevation of your mouth or closing of your mouth. Let's see about the lateral pterygoid muscle. The lateral pterygoid have superior fiber and the inferior fiber. The upper or the superior fiber is originated from the superior head. Superior head is originated from the infratemporal surface and the infratemporal crest of the greater wing of sphenoid bone, and the lower inferior fiber is originated from the lateral pterygoid plate. It is inserted at the condyle of mandible. The nerve supply is by trigeminal nerve. The main action of lateral pterygoid muscle, if it is working unilaterally, means it is helping in the contralateral deviation of your jaw. If it is working bilaterally, both the side, it will depress or open your mouth or protrude the mandible. Let's see the osteokinematic of a temporomandibular joint. This is protrusion, retrusion, depression means open, elevation means close your mouth, lateral excursion, deviate your mouth. Let's see arthrokinematic motions of temporomandibular joint. Here we can see that this is temporal bone, this is normal opening of temporal bone, this is articulated disc. Here during depress or opening, the mandibular condyle rotates antero-inferiorly, means this way antero-inferiorly. The condyle and disc both glide anteriorly and inferiorly over the articular tubercle of temporal bone. Let's see about the elevation or closing the disc. This is normally closed disc, temporal bone, disc, condyle, mandible and teeth. So when there is a mandibular condyle rotates posteriorly on disc, this is mandibular condyle, this is rotate posteriorly on this disc. The condyle and disc both glides postero-superiorly over the articular tubercle of temporal bone. This is articular tubercle of temporal bone. So the disc and condyle both move postero-superiorly during elevation or closing the mouth. About the lateral deviation, it is always occur in the transverse plane. For an example, this is right side of your mouth, left side of your mouth, and this is lateral excursion of your mouth. When for an example, if we are moving mandible towards left side, like this way, if we are moving our mandible, the left condyle is rotating around the vertical axis, and the right condyle, it is glides anteriorly and inferiorly. So same thing occur if we are taking to the deviation on right side. Let's see about the protrusion and retrusion. When there is a protrusion or retrusion, there is no rotation. The mandibles move anteriorly in protrusion. The mandibles move posteriorly in retrusion. So the mandibular condyle and disc move as a one unit against the articular fossa of temporal bone. During the protrusion, the retrodiscal lamina moves 6.9 mm in protrusion and 3 mm in retrusion. Let's see muscle and ligament control during mouth opening. In this diagram, this is superior portion of lateral pterygoid, inferior portion of lateral pterygoid, disc and condyle, temporal bone, masseter muscle. If we see this, disc is controlled passively by capsule and ligament, actively by muscle. So let's see. If the inferior portion of lateral pterygoid muscle is contracting during mouth opening, it will pull out and inferiorly rotate the condyle. That's why the disc is depressed anteriorly and open the mouth. During opening the mouth, masseter muscle is pulling down, and that's why mouth opening is occur. Let's see about closing of our mouth and how muscle work will be there. During closing of our mouth, the superior fiber of lateral pterygoid muscle will contract eccentrically, and this is help to control the posterior movement of your disc. So therefore disc movement will occur upward and posteriorly. We can see here it will go for upward and posteriorly. The posterior directed force of superior lamina is also help to hold it posteriorly, and this way the closing of mouth will occur and it is maintained until the condyle completes its rotation posteriorly. Examination of temporomandibular joint. So first we need to check the history. Either there is a jaw restriction is there or not, mouth opening is limited or not. If it is limited, so it is limited opening is intermittent or it is progressive. Intermittent means limited mouth open will be there and it will be resolved. Progressive means patient is having a different kind of a fibrosis problem and it will be progressive. We have to check the muscle tightness and capsular pattern and the capsulitis. If our lock of the teeth is there, then it will be because of some mechanical disorder into the joint. That means it is internal derangement, and that's why the deviation of mandible in opening or closing will be there. If it is affected internally, so opening and closing of mouth is also affected. If there is a pain during jaw open, so opening pain it will be there, so there will be intra-articular origin. It is related to disc or its degeneration is there. As we are physiotherapists, so we need to inspect the temporomandibular joint. So what we are going to inspect in this? First, we are going to check the asymmetry. If the muscle asymmetry is there or mouth opening asymmetry is there, mouth closing asymmetry is there or not. If patient is having some swelling, the masseter muscle and the temporalis muscle are hypertrophied or not. Because the masseter and temporalis, they both are mastication muscle. We need to check about the forwarded head posture. Because the forwarded head posture will affect our teeth. When there is a forward head posture, our anterior teeth will occlude first. We need to check the range of motion of opening, closing, lateral deviation, protrusion and retrusion. Either it is normal or abnormal. During inspection, we need to check about the malocclusion. So what is malocclusion? It is deviation from normal occlusion. It is improper positioning of teeth or jaws. If we are checking the jaw deviation, first we need to check about the lateral deviation. The lateral deviation, malocclusion of upper teeth or hypertone of our masseter muscle, because masseter muscle is our chewing muscle. So it causes adaptive shortening of mastication muscle, and that's why we have ipsilateral side deviation and lengthening on contralateral side. So we need to check either we have cross bite, underbite or overbite. Cross bite when teeth of the mandible are lateral to the upper maxillary teeth on one side and medial on opposite side. Underbite means the mandibular teeth are anteriorly to the maxillary teeth, either unilaterally, bilaterally or in pair. Overbite means it is occurring during the anterior maxillary incisor extends below anterior mandibular incisor and the jaw is in central occlusion. This is from the Dutton explanation. Let's check the normal range of motion. It can be measured by upper incisor and the lower incisor. In between we have to use the scale. The normal opening is 35 to 40 mmHg. If it is less than 40, so opening is restricted. And if opening is restricted, we need to check the ENDFEEL, which describe the characteristic of restriction. The ENDFEEL can be evaluated by placing the fingers between patient's upper and lower teeth and apply gentle and steady force. Let's check the deviation on opening. If the opening pathway is deviates from straight opening, but in midline relationship it returns to a normal maximum opening. Here we can see this. This is deviation to opening. That means the patient is having some problem with muscles. Let's check about the examination. If the lateral excursion on opening is affected, means lateral deviation is affected on contralateral side, medial and lateral pterygoid muscle is contracting and ipsilateral masseter muscle is contracting. Let's see here. Here right side deviation is occur. So right side masseter and left side medial and lateral pterygoid is involved. If deviation occur during opening, means jaw returns to midline before 35 to 50 mm of total opening, then it is associated with disc derangement. If the speed of opening is altered, the location of deviation is also altered, and that indicates the disc movement. That indicates disc displacement with reduction. The speed is not affected, that means there is some structural problem. If the muscle which is laterally, that means masseter or temporalis, affected, the deflection will be towards the involved side, means same side. If the medial joint, means medial pterygoid is affected, so the deviation will be away from the involved side, means contralateral deviation. If intracapsular mandible is affected, then movement will be towards the involvement of joint, means same side of the joint. If there is a shortening of muscle, so then how we should know that it is contralaterally or ipsilaterally deviated? It always depends on the position of that involved muscle. So mandible will always move on the affected muscle side. Let's see about the normal and abnormal ENDFEEL. So during mouth opening, it will be tissue stretch. During closing, the bone to bone ENDFEEL will be there. Protraction, retraction and lateral deviation, tissue stretch will be there. So when there is a hard ENDFEEL, so it is osseous abnormality. That means bone is affected. If springy block is there, we can see that it is associated with disc displacement. If capsular ENDFEEL is there, that means it is associated with shortening of periarticular tissues. Let's go for the palpation. So first of all, if we are palpating, we need to put the fingers into the external auditory meatus and ask the patient to open and close the mouth. So at that time we can check the movement of that joint specifically, and we can feel the movement, and especially while this movement, if the patient is feeling clicking, that means in opening and closing they have reciprocal click, that means disc is displaced anteriorly. Then we are going to auscultate. So if there is a poor kinematics, so at that time we need to auscultate the patient. Let's see about some differential diagnosis of a temporomandibular joint. So first is inflammation. The inflammation is occurred due to repetitive injury, trauma. If the patient is immobilized after some surgery, if the patient is injured their cervical spine, so they have some immobilization, and because of that they feel some inflammation in TMJ. If the patient has done some TMJ surgery or dental surgery, then they have inflammation. So what are the signs and symptoms of inflammation? The first sign and symptoms is decreased opening. So remember, if your mouth is open less than 40 mm Hg, either you have problem of inflammation, that if you are having capsular pattern, if the patient is having capsular tightness, that means there is inflammation. Pain may be with or without movement. So first we need to check the disc displacement, like disc is going anteriorly or posteriorly. Then second we need to check the disc displacement. Disc displacement commonly occur in anterior position. Rarely it will occur in the posterior position. If the patient is having forward head posture, means poor posture, so disc displaced anteriorly, excessive opening is there, muscle imbalance is there. These all are pathomechanics of disc displacement. What are signs and symptoms for disc displacement? First, we need to check that disc displacement is with reduction or without reduction. If the patient is having muscle guarding, headache, so disc displacement is always diagnosed with MRI. Without that, we cannot confirm the disc displacement. Then lastly, arthritis. Arthritis is always gradual onset. Patient may have trauma, poor kinetics, joint erosion. The signs and symptoms like pain, stiffness, clicking, grinding. Patient is having decreased range of motion toward the affected side. So remember, in inflammation and in arthritis, patient is having decreased range of motion. So in arthritis, patient is having grinding and pain, stiffness and clicking and deviation toward the affected side. In inflammation, the opening is decreased, capsular pattern will be there, pain will be there but with or without movement. So we can differentially diagnose like this way. Let's see about the disc displacement with reduction and without reduction. So when we have disc displacement with reduction, patient will have symptoms like clicking and popping, they feel catching, reciprocal click will be there, especially the protrusion, active protrusion is limited, and they have no problem in active range of motion. But in disc displacement without reduction means closed lock. Your jaw is locked in closed position. So patient, whenever he is opening the mouth, they have a sound like clicking, and especially if they open their mouth, the active range of motion during opening is limited. So opening is limited up to less than 40 mmHg. Lateral deviation is also there, protrusion is also affected, but sometimes there won't be any reciprocal click sound is there. So there is only late sound is there because disc displaced anteriorly in late phase. See about the capsulitis. So whenever patient is having capsulitis or capsular problems, so active range of motion limitation will be there, and especially patient is have pain in front of the ear. It will be exacerbated by jaw function, like opening patient will feel more pain, and especially it is limited by your function is limited due to the pain. If you are palpating this patient, so they are having a tender point in their TMJ, especially while clenching the teeth, pain is worsened. So limited active mandibular range of motion and lateration and the protrusion is affected in capsulitis. Let's see about some muscle spasm and its sign and symptoms. So whenever patient is having muscle spasm, especially the mastication muscle, because it is mostly used muscle, and that's why it is most common affected muscle, mainly due to trauma or immobilization. If patient is having some kind of the problem like some spinal fracture is there, so at that time immobilization will be there, and that's why they have some muscle spasm. The prolonged symptoms, like if the patient is having masseter and temporalis problem, so they have fatigue while chewing, especially when patient is doing some vertical range of motion, they have this kind of problem. In early phase, muscle incoordination and jaw click is there, so there will be subluxation. If in middle phase muscle spasm is there, so mandible movement is affected, and in later phase muscle is shortened, fibrosis is there, and it is irreversible, so we need surgery. Only in early phase we can help the patient, and in the later two phases we need to send them to their doctor. Let's see about physiotherapy management for muscle spasm. So if it is in early stage, we can help the patient. Give moist heat to relax the muscle, especially the affected area. We can massage that muscle, and active and active range of motion, especially self-stretching exercise, we need to teach them. Ask the patient to avoid forward mouth opening. It will exaggerate the symptoms. That's why we are telling to stop the exaggerating mouth opening. Especially retrusion exercise of lateral pterygoid muscle is indicated. Let's see the acute phase TMJ problem and its management for physiotherapy. When the patient is having trauma, there will be internal derangement. So there is sudden lock, typical capsular restriction is there, and that means patient mouth opening is decreased, especially decreased ipsilateral mouth opening and lateral deviation. There is a tenderness on affected site. So if the patient is having acute phase, so what is our duty as a physiotherapist? We can protect, we can give ice therapy, especially the cold therapy reduce edema and inflammation. When the patient is having muscle spasm, cold therapy is also good. Especially we need to teach the patient not to eat hard food, they should eat soft food. Manual therapy in early range of motion, especially pain-free range of motion exercise is indicated because it stimulates the mechanoreceptors. Ask the patient to avoid the stress and teach them some stress avoidance technique, because during stress patient will clench their teeth. Especially tell the patient not to sleep on affected side. Let's see some functional phase exercise. When the patient is having functional phase, so at that time we need to teach them some postural re-education exercise, especially to correct the forward head posture, because in forward head posture your TMJ dysfunction is occur. Ask the patient to apply the moist heat because it relaxes the muscle and improves circulation. If we are applying 15 minutes for moist heat, then it will relax your muscle. We can use ultrasound with 3 MHz, 0.75 watt per centimeter square. It relaxes our muscle and increase the circulation. Guys, if you have any doubts related to any topics in NPTE or PCE, please let me know in my comment section so I can make videos on that.